respiratory tract infections, these are the most common infections that people come across. And these are the most common infections women have, especially in the reproductive age group of women. So, what are the risk factors for urological or urinary tract infection? Of course, a frequent sexual intercourse, new sexual partner, a previous urinary tract infection in last 12 months, and of course, use of diaphragm or spermicides. These are some of the common causes of young reproductive age group women. Other than that, factors like diabetes, anatomic abnormalities in the urinary tract, which actually act as a factors to compound and increase the risk factor for urinary tract infection, and also in case of males, lack of circumcision and presence of chronic indwelling catheter. These are some of the important risk factors. Now, coming to the organisms which are responsible for urinary tract infection. As we know, E. coli is the most common organism that is responsible for urinary tract infection, responsible for around 80 to 90% of patients. Along with that, of course, other gram-negative organisms like Klebsiella, Proteus, and Enterococcus are also very important agents responsible for UTI. Sometimes we also have gram-positive organisms such as Enterococci and Staphylococcus as responsible for causing urinary tract infection. Now, what are the factors which are responsible? The interplay of factors, some contributed by the organism, such as the virulence of the organism. Some contributed, this is the slide I was talking about, interplay of factors between the organism, the host, and the environment. The organism and its virulence is very important. The host, along with its various genetic factors, are very important. The host genetic factors like and other certain genetic factors predispose the host towards recurrent urinary tract infection. Along with that, the underlying disease, if the patient has got diabetes or other immunosuppressive condition, then there are tissue-specific receptors. Along with these two host and organism factors, the local environment of the urinary tract, the local vaginal ecology, anatomical or urological or urinary retention abnormalities, and if there are any indwelling medical aspect, we have to look into and take care of this aspect. How does a urinary tract infection actually manifest? It manifests in terms of asymptomatic. There are different categories based on the manifestations. That manifestation usually is decided by the area of infection, the involvement of which part of the urinary tract. The most common involvement of urinary tract actually is asymptomatic. Where there is asymptomatic bacteriuria, there are no local or systemic symptoms which can be referred to. Only on an occasional examination of the urine, this kind of patients. The next most common in this case of patients is lower urinary tract infection, where the patients have got dysuria, increased frequency and urgency. Sometimes they also have got nocturia, hesitancy, suprapubic discomfort. If the patient has got an upper urinary tract involvement, then in these patients, sometimes cystitis leads to upper urinary tract infection. That leads to flank pain or fever. Pyelonephritis is the term itself indicates involvement of the upper urinary tract, and obviously this also indicates that the infection is more serious. The manifestations are also of more serious nature, with high rise and spiking of fevers along with the rigors. Sometimes there are other manifestations like nausea, vomiting. Flank pain and loin pain is one of the very common manifestations, common symptoms with which a patient comes to us in the OPD or in the emergency. Sometimes these patients can have more serious consequences with papillary necrosis, and of course, if the fever or bacteremia continues despite of antibacterial therapy, then these patients would basically have got what we suspect as intraparenchymal abscess. Then there are certain specific categories of pyelonephritis, such as emphysematous pyelonephritis, which is a predominantly thing happening in diabetic patients with involvement with actually a necrotizing involvement of renal parenchyma with production of gas. Similarly, xanthogranulomatous pyelonephritis is a condition which happens associated with chronic urinary tract obstruction. These are some of the more serious forms of pyelonephritis. Now, coming to the next slide, We will not go into the very details of individual cases. Our focus is basically on a general care of urinary tract infections in day-to-day practice. How do we go for testing? How do we go for diagnosis? Of course, if you have a basic urine examination, a positive dipstick test, positive leukocyte esterase test, all these can, and positive pyuria in routine urine examination, sometimes associated with hematuria. These are some of the indicators. Urine culture is actually the gold standard for diagnosis of urinary tract infection. And urine culture, along with the colony count, especially the colony count, if it is more than 10 to the power 2 in case of women, and in case of men, if it is more than 10 to the power 3, and asymptomatic bacteria, if it is more than 10 to the power 5 of bacterial count for colony forming units per ml. All these are indicators of diagnosis. Now we'll focus on some of the simple as approach towards treatment. Of course, when you have a culture best, then of course it's easy. But what do we do before we get a culture? Some of the common antibiotics which are very effective in case of urinary tract infection are nitrofurantoin, trimethoprim, and sulfamethoxazole, fosfomycin, and fluoroquinolones, beta-lactams. The fluoroquinolones, often a single dose of fluoroquinolone would be good enough to get rid of one infection in these patients. So these are some of the common antibiotic agents which are most commonly being used, such as nitrofurantoin, trimethoprim, sulfamethoxazole, and fluoroquinolones. Okay, having had a brief discussion on UTI, we will switch over to the next broad category of our discussion, that is acute kidney injury. Acute kidney injury, earlier it was referred to as acute renal failure. Now we more specifically call it as acute kidney injury. As you all understand, acute kidney injury is an abrupt reduction in kidney function which is evidenced by a change in the values of serum creatinine, blood urea, nitrogen, and of course decreased urine output. How do you define acute kidney injury? If the serum creatinine level is more than 0.3 milligram per deciliter within the last 48 hours, if there is a 50% increase in serum creatinine over the baseline values within last 7 days, or if the urine output is less than 0.5 ml per kg per hour for at least last 6 hours. When we come to acute kidney injury, we can go to the next slide. There are basically um, it is understood how common acute kidney injury is, that it may not be so common in outdoor practice, but in hospitalized patients, irrespective of whatever condition they are admitted with, if they are admitted with anemia, if there are some gynecological disorder, sepsis, road traffic accident, or other multisystemic infections, all these things can lead to acute kidney injury. So it is common, almost 5 to 7% of all hospitalized patients have got UTI at some point or the other time. And UTI, I'm sorry, I was talking about AKI at some point or the other point of time in their hospitalization. Now, AKI also complicates the overall prognosis of the disease. AKI has to be categorized, have to be classified depending on the severity grade. So all of you must have come across terms like a rifle, and you might be using these criteria in our day-to-day practice. I'll just go through some of the broad categories. One is rifle category, one is acute kidney injury network category, and another one is KDIGO criteria. So, as I was telling, there are various rifle criteria, acute kidney injury network criteria, and KDIGO criteria. All these criteria are basically divided based on how fast the creatinine rises and how rapidly it rises. As you might know, in the rifle criteria, there are basically first three categories are risk, injury, and failure. The fourth category is loss. So if a acute kidney injury persists for more than 4 weeks, then the patient might land up in loss of kidney function. But if it persists for more than 3 months, then it might land up in chronic kidney disease or end-stage kidney disease. So out of the various risk factors for chronic kidney disease, acute kidney injury is very, very important. Earlier, we always thought that if a patient has got acute kidney injury and he or she is going to recover, then there is no problem. They will have a reasonably normal life. But now we understand that once an acute kidney injury happens, there is a lifelong risk for chronic kidney disease in these patients. So it has to be borne in mind. Now, talking about the various causes of acute kidney injury. Since our MBBS days, we have understood that acute kidney injury has to be categorized into pre-renal, intrinsic acute kidney injury, and post-renal causes. Pre-renal causes predominantly focus on causes arising out of volume depletion. If there is a hemorrhage, there is a GI loss, or acute gastroenteritis. There can be other cardiac causes like decreased cardiac output. Uh, these are some of the pre-renal causes. Some of the functional causes contributing to pre-renal are NSAIDs, ACE inhibitors, ARBs, all these agents. Now, coming to intrinsic acute renal failure, these can involve structures within the kidney. This can be at the vascular level, this can be glomerular involvement, this can be acute tubular necrosis or acute interstitial nephritis. Similarly, there is another category which is post-renal acute kidney injury. Now, all these factors will lead to common clinical presentations. The clinical presentations are common irrespective of the background cause of AKI, which starts with, of course, peripheral edema, weight gain, nausea, vomiting, mental status changes can also happen, and typical phases of fluid overload such as shortness of breath and sometimes pruritus due to deposition of uremic toxins, even in case of AKI. So, how do we approach for treatment of AKI? Mostly treatment of AKI is supportive. I mean, most of the patients respond to supportive care. If there is a patient who has got a fluid deficit, then adequate fluid and electrolyte replacement in this case of patients, and correction of hematological abnormalities. All drugs should be reviewed in these patients. If there are any drugs which are contributing to AKI, they have to be looked into. Now, coming to pharmacologic therapy. If the patient has got fluid overload in the initial stages of their disease, they may respond to treatment with loop diuretics, and it's usually advised unless and until but later on the patient may not respond to loop diuretics, and this point of time it may really be harmful to give these patients or treat these patients with loop diuretics. Therefore, it is important that at the early stage we give these patients loop diuretics. If they respond, it's well and good. The next thing, serum electrolytes should be monitored. Hyperkalemia is most common in serious abnormality. As I was telling, hyperkalemia is a very serious abnormality. We should try to monitor it with anti-hyperkalemic agents. Other electrolyte abnormalities should also be monitored. But if they do not respond, then what is important is, when do we decide to go for a renal replacement therapy in patients with AKI? Important aspects: if the patient has got very high urea and creatinine, especially, and the potassium level, if the potassium level is very high, the patient has got diuretic resistant fluid overload, or if the patient has got metabolic acidosis. The point is, if the patient is not responding to conservative measures, it is better to go ahead with early replacement of renal replacement therapy such as dialysis, hemodialysis, or peritoneal dialysis, but mostly in ICU setups, it's better to go for hemodialysis. And most of the conservative strategies that earlier were used, like using low dose dopamine and all, they do not really have much role in these patients. So it's better that we go ahead with our strategy of hemodialysis or peritoneal dialysis whenever the situation demands. Then we go. Now, the next most important entity in our discussion is nephrotic syndrome. As you know, nephrotic syndrome is not a disease. It's a symptom complex arising out of various primary causes. It is characterized by, we all know, there are four basic elements: edema, hypoalbuminemia, and proteinuria. Actually, proteinuria is the reason which gives rise to hypoalbuminemia, which gives rise to edema. Along with that, these patients also have hyperlipidemia. These patients actually present with nephrotic range proteinuria. Now, not all proteinuria is nephrotic range. Nephrotic range proteinuria, if the urine protein is 3 plus per flow plus, spot urine protein creatinine ratio is more than 2, or urine albumin expression is more than 40 milligram per meter square, or urine protein expression is more than 50 milligram per kg per 24 hours. In our standard understanding, since our college days, we have understood, we have read that if the proteinuria is more than 3.5 gram per 24 hours, but there are other refined use of these various values, because it's always not possible to get a 24 sample for protein estimation. There are other important elements such as hypoalbuminemia and cholesterol being more than 200, and of course generalized edema. There are various causes of nephrotic syndrome. The most common, of course, is 95% of cases is primary glomerular abnormality, and the remaining are secondary abnormalities. There can be various rare causes, but important causes such as Finis type congenital nephrotic syndrome. The list is far from complete here, but I will not go to the individual causes here. It is also important to remember, as you see on the right side of the slide, there are certain drugs which can contribute to nephrotic syndrome, such as penicillamine, gold, and one of the most common agents which can cause nephrotic syndrome is, of course, NSAID use. This is also something we should keep in mind. Well, as we go to the next slide. Uh, what are the basic evaluation other than as routine urine examination? We also have to go for a evaluation of renal function, evaluation of albumin levels in the blood, complete blood count, tuberculin test, and also certain serological evaluation like C3, C4, ANA, sometimes ANCA, anti-dsDNA. As we know that lupus is also an important cause of nephrotic syndrome, you have to go for serological evaluation as HIV, SBV, HCV. All these agents are important in general, and also individually also they can contribute to nephrotic syndrome by various glomerular pathology. And of course, we have to go for a chest X-ray to see if the patient has got a history of tuberculosis or history of contact with tuberculosis. Now, all patients who are above 11 years of age with nephrotic syndrome should undergo a kidney biopsy. But those patients who are between 1 to 11 years of age, they do not go for kidney biopsy. Especially children, we do not go for kidney biopsy unless and until. What are the indications? This slide basically indicates what are the causes, what are the situations where we go for kidney biopsy in children. One is age of onset. If it is less than 1 year, if the patient has got gross hematuria, if the patient has got sustained hypertension, if the patient has got renal failure not attributable to hypovolemia, and suspected secondary causes of nephrotic syndrome. And also if the proteinuria is persisting despite 4 weeks of daily corticosteroid therapy, that is if the patient has got steroid resistance. So we go for look at the clinical presentation, because it is important for symptomatic treatment such as fluid retention, anorexia, hypertension, oliguria, orthostatic hypertension. There are stria on the skin, and of course foamy urine. Often the patients complain of foamy urine. That is the first complaint they have, apart from obvious signs such as abdominal distension, ascites, edema, and puffiness around the eyelids, scrotal swelling. All these signs of fluid retention, these are some of the common clinical presentations. And this is one more slide which indicates causes of nephrotic syndrome. The primary causes, as we all know, that minimal change disease is the most common cause of nephrotic syndrome in children, and membranous nephropathy, focal segmental glomerulosclerosis, MPG, and IgA nephropathy are some of the other common causes of nephrotic syndrome. IgA nephropathy is one of the most common glomerular disease we have in our country and across the world. It is also responsible. All these causes are very, very important, because if not treat these causes at the early stage, they can lead to chronic kidney failure or derangement of kidney function at a later stage. Now, how we go about treatment of nephrotic syndrome? What we normally do is, in these conditions, prednisolone is our good old prednisolone. It is still the drug of choice. We start at 2 milligram per kg per day for 6 weeks, followed by 1 milligram per kg as a single morning dose on alternate days for the next 6 weeks. Then therapy is discontinued, of course, by monitoring the labels of urine protein, whether the patient has gone into remission or not. That is important. We have to look into that. Here it is important that even after going to the remission, not all patients remain in sustained remission. Now we have to remember, keep in mind few of the definitions in relation to the treatment of nephrotic syndrome. One, if the urine albumin is nil or trace for 3 consecutive days in early morning urine samples, then we define it as remission. However, If a patient has undergone remission, again urine appears 3 to 4 plus for 3 consecutive early morning samples, then the patient is said to have having a relapse of nephrotic syndrome. Now, if the same relapse has happened more than 2 in 6 months or more than 3 in 1 year, remember, more than 2 in 6 months or more than 3 in 1 year would suggest the patient having frequent relapses. If it is less than that, less than 3 per year, it is infrequent relapse. Now, how do we call it as steroid dependence? Many times you must have seen patients being described as steroid dependent nephrotic syndrome if there are 2 consecutive relapses when an alternate day steroids or within 14 days of its discontinuation. What is steroid resistance? If there is failure to achieve remission despite steroid therapy with daily prednisone at a dose of 2 milligram per kg per day for 4 weeks. So these are some of the terms related to nephrotic syndrome and its management. And these are some of the management strategies as I just enumerated. We obviously will not go to the individual details of it, and I have told the various definitions. If a patient has got steroid resistance, then maybe we'll have to go for secondary agents such as cyclosporin, tacrolimus, mycophenolate, azathioprine. These are various agents which we would like to use if the patient is steroid resistant. But most of the times, if a patient has got steroid resistant nephrotic syndrome, then they have to be and they must be referred to a nephrologist for more specialized care. Now, the most important and most attention demanding entity in nephrology is chronic kidney disease. How do we define chronic kidney disease? Whenever Why it is so important for all of us to understand about chronic kidney disease, because it's not just nephrologists. Primary care physicians can play a significant role in early diagnosis, treatment, and patient education. A greater emphasis on dictating chronic kidney disease and managing it prior to referral can also improve the patient outcome. As I want to emphasize once again that CKD is a part of primary care. The public burden of CKD is enormous. Even this year, World Kidney Day, the message was like kidney care for everyone and everywhere. Because the global burden of kidney disease is increasing, CKD could be or is at this point of time one of the leading causes of, uh, it is the fifth leading cause of death from chronic diseases all over the world. So as you all understand, CKD is a very significant public health burden. It is also important for the point of view that CKD, CVD, that is cardiovascular diseases and diabetes, they are all interrelated, and CKD often acts as a disease multiplier. It compounds the overall morbidity and mortality from diabetes. It also compounds overall or morbidity and mortality for from cardiovascular diseases, because chronic kidney disease is an independent cardiovascular risk factor in most patients. What are the CKD risk factors? There can be modifiable risk factors such as diabetes, hypertension. Diabetes is the most common cause of chronic kidney disease, followed by hypertension. As I had earlier mentioned while discussing AKI, a history of AKI is important, and frequent use of NSAID is also important. Other non-modifiable risk factors, of course, if there is a family history, you cannot change that. If the patient is increased age, every person more than 60 years of age is itself is a risk factor for chronic kidney disease. Now we have to estimate the EGFR for gradation and categorization of chronic kidney disease. EGFR can be estimated with CKD-EPI creatinine equation. Other common EGFR methods for estimation is MDRD, and the most commonly used on our OPD practice is Cockcroft-Gault formula that you all know. That is 140 minus age multiplied by serum creatinine multiplied by body weight divided by 72 into serum creatinine. That is how we define as Cockcroft-Gault formula. Now, how do you define what is the criteria for particular patient to be called as a CKD case? Abnormalities of kidney structure function which are present for more than 3 months with implications for the health. Or else either of the following must be present for 3 months or more than 3 months. One is acute albumin creatinine ratio being more than 30 per milligram per gram, or other markers of kidney damage such as the patient may have a history of nephrotic syndrome, nephritic syndrome, tubular syndromes, urinary tract symptoms, asymptomatic urine analysis abnormalities, asymptomatic radiologic abnormalities, hypertension due to kidney diseases. And all this can be contributing factors for these patients. How do we classify CKD in various severity criteria? Chronic kidney disease is actually, according to the GFR, is classified into 5 different stages. Stage 1, when the GFR is more than 90. Stage 2, of course, 60 to 90 or 60 to 89. Stage 3, 30 to 59. Stage 4, 15 to 29. And stage 5, when the GFR is less than 15, the kidneys can no longer keep up with the function of removing waste and extra water. This is called kidney failure or end-stage kidney disease. These point of time, patients usually require renal replacement therapy. As we classify chronic kidney disease according to the various categories, now recently there have been some subcategories that have been added, and there are, along with that, other important markers. It's not just the GFR; it is also the albumin labels which impact the overall prognosis. Now, stage 3 in this category has been divided into stage 3 and stage 3B. Now mark one of the boxes over here. A patient having a GFR of 50 but having significant albuminuria is actually at a more severe risk of prognosis to end stage renal disease than compared to a patient who would be having GFR of between 30 to 44. So it is both the GFR along with albuminuria which will decide risk of progression to future end-stage renal disease or progression to further higher stages. Now, how do we approach to these patients as primary care providers? We recognize and test these patients, educate about the various risk factors or uh, consequences of chronic kidney disease. And most important thing that we can do, even without realizing how important what we are doing, is management of the blood pressure and management of diabetes. As I told, it is responsible for 60 to 70% of cases of chronic kidney disease. We also address other cardiovascular disease risk factors, and of course, we monitor the proteinuria levels and the deterioration of GFR, how fast the GFR is deteriorating. As we know that CKD is a progressive disease. We also monitor and manage anemia, malnutrition, CKD, MBD, and other complications in at-risk patients. And if we have a dietitian, we can take advice from a dietitian about protein restriction in the diet and other safety issues in patients with CKD. Having done all that, then we get some time to consult a team with a nephrologist. You do not always have to entirely send a patient to a nephrologist. If you are a primary care physician and they are in a far place from main cities where there are nephrologists or a nephrology setup is located, then once in a while the patient can go to nephrologist, but rest of the time the patient can be managed with the physicians at his local level for his blood pressure control, for his blood sugar control. That actually is a teamwork. Teamwork is always better than an individual responsibility, either on the part of the primary care physician or a nephrologist. None of them can take care of the patient individually. It's a teamwork which is very, very important. Basics of transplantation. Where do we need? Before going for discussion about transplantation, I just skipped one or two things in the management of chronic kidney disease, because in chronic kidney disease, when patient lands up into end-stage renal disease, there are two modes of treatment. Either we give dialysis to these patients or we go for kidney transplantation. Dialysis, of course, when GFR is less than 15, dialysis is the modality with which a patient sustains or a patient is able to live with dialysis. But dialysis is very, very it's a financial and social burden on the patient, and gradually it impacts the patient's emotionally and a psychological level also. Therefore, if a patient can go for successful kidney transplantation, that is, a healthy kidney from a healthy donor is transplanted into the body of the body of the recipient, then of course this is going to be the most effective therapy for this patient. Now, transplanted organ in case of a live donor can come from a healthy donor, or in case of a deceased donor after satisfying certain criteria. Most of the deceased donors come from brain dead donors. They can be there can be expanded criteria donors as well as donation after cardiac death. This actually increases the risk of deceased donor transplantation in specific cases. But having said that, kidney transplantation continues to be the most effective strategy for end-stage kidney disease. The burden is huge. A lot of patients will require kidney transplantation. Despite that, we are able to give transplants to a minimum number of patients, out of which, again, most of the transplants are living donor transplants, and out of the living donor transplants, 60 to 70% are live related, and only 30% are live unrelated. And deceased donor transplant is very low. Obviously, to give more and more kidneys to needy patients, we need to increase the deceased donor transplant program, and more life donors have to come forward from within the families. And if they come from outside families, they have to come through proper procedures that are being set by different state governments all over the country. When do we refer a patient to a nephrologist? As I told, if the patient is in CKD stage 5, the patient obviously requires stage dialysis. But in CKD stage, it gives us the time to mentally prepare the patient that they are going to require dialysis in a short span of time. So therefore, when the GFR is less than 15, or more specifically it is less than 20, we refer a patient. Patients with diabetes actually progress relatively rapidly. So there is no sense of delaying in these patients. If a living donor is available, no sense of delaying transplants in these patients. And if the patient is clinically uremic, obviously we go for dialysis and counseling for transplantation. One of the very important aspects in these patients, in most of the patients with CKD, is our responsibility to tell them about preemptive transplantation. Now, what is preemptive transplantation? We all understand that patients who have landed up into end-stage kidney disease will require dialysis, and after that, we give them a transplant. But those patients who want to opt for transplantations, having understood the obvious consequence of CKD is going to be, the inevitable consequence of CKD is going to be resulting in dialysis. If they opt for transplantation even before the starting of dialysis, then we call it as preemptive transplantation. And study after study has shown that preemptive transplantation has one of the better outcomes, one of the best outcomes as compared to transplantation after starting of dialysis. Whom do we refer? We refer to a center with, especially with for transplantation, we refer to a center where there is a complete transplantation setup with a transplant coordinator, counselor. They would tell about the counseling aspects of the transplant, the costs associated, the risks and benefits. And if there is a deceased donor transplant program going on, they will make the patient and the relatives aware about the organ waiting list enrollment procedure. And of course, the hem of affairs in both these cases would be the nephrologist and the transplant surgeon. They would exactly evaluate the patient and also give them exact details about the medical aspects of it. And the surgeon, of course, has to evaluate what are the risks associated with the and pre-transplant evaluation, and how surgically compatible the patient is to receive a kidney transplant. Obviously, why I told transplantation is so important, because it gives prolonged survival and improved quality of life, not just in terms of years of life. It also adds to satisfaction, various satisfactory goals in life, physical and emotional well-being, and ability to return to work, which is much higher in case of transplant patients. There is another important aspect that most of the times we neglect. The patient has a return of fertility, and most importantly, patient is free of dialysis. There are other, of course, improvement in anemia and bone disease. And if we compare, the overall end results are also cheaper in case of transplantation as compared to dialysis. As I told, it gives survivability advantages. So the annual mortality rate of patients under dialysis ranges from 21 to 25%, but it is less than 8% with cadaveric transplants and less than 5% with living related transplants. So the benefit of transplantation is again most notable in young people, in those with diabetes mellitus. Obviously, the projected of years of life in both diabetic and non-diabetic patients are increased by many years. Therefore, it is our responsibility to counsel the patient about kidney transplantation and give them the advantage of kidney transplantation if they are willing to go for it. So these are the various stages. Once again, summarizing, if a primary care practitioner can manage the patient up to CKD stage 3, at CKD stage 4, they have to team up with a nephrologist and manage the patient combinedly. However, if the patient lands up into CKD stage 5, then obviously the patient has to be under complete care of a nephrologist. But if a primary care physician takes care of the patient in early stages, teaming with that of a nephrologist, then many times we can delay the progression of chronic kidney disease. That is our most important goal, because we cannot entirely reverse the process, but we can delay the progression so that the patient does not land into end-stage kidney disease at an early stage, and we can go on delaying the progression of CKD for a significant period of time. So the take-home points, obviously, all the primary care physicians, along with the people who are practicing treatment of diabetics or uh, other aspects of, or general care practitioners in distant places, they all play an important role in identifying risk factors, knowing the patient's GFR status, knowing the patient's progression, adjusting the medication of the patient, adjusting insulin, adjusting anti-diabetic doses, and adjusting antihypertensives, modifying the patient's dietary strategy, then of course partnering and referring the patient to a nephrologist, to a specialist. With that, I would conclude this presentation. Thank you very much for your attention once again.
Yeah, thank you, sir. Thank you so much for your expert insights. There are few questions. Uh, sir, there are few questions which
Yeah,
have
why
come.
not? Please go ahead.
Uh, yeah, so we'll take couple of questions. Like, doctor is
Absolutely.
saying that thank you for heat map. We should have that heat map displayed in our clinics, and so we'll be
Yeah,
able to know about the stages of the CKDs. He is saying that in general practice, we are always concerned about NSAID, prescription of NSAIDs. What would be your expert advice on this?
actually, NSAIDs are a risk factor for chronic kidney disease, and we should be very much concerned when we are going to give NSAIDs for a patient for a prolonged period of time. Look, what is more important is that if a doctor advises NSAIDs, then obviously it's under prescription, and they know exactly for which condition they are prescribing and for how many days they are prescribing. What is more worrisome is that when the patients start taking of NSAIDs as over the counter prescription without the advice of a doctor, then many times they go on taking it for a number of days, and as and when required they just go on taking it. So it is at those point of time, prolonged use of NSAIDs is a risk factor for chronic kidney disease. And if a doctor is prescribing, they have to be mindful of monitoring the kidney function. And for simple ailments like the patient has got fever and body ache, then we can do with simple paracetamol without giving typical NSAIDs such as diclofenac or ibuprofen, which can have a impact on the kidney disease. If paracetamol can manage, then we may have to handle with that without giving patients for a prolonged NSAIDs for a prolonged period of time.
Yeah. Sir, can we have a proper list of nephrotoxic drugs in specialist point of view? Mnemonics would be preferable.
Look, the list of nephrotoxic drugs, we have to broadly understand that NSAIDs are nephrotoxic drugs. In terms of antibiotics, aminoglycosides are nephrotoxic drugs. Then other group of nephrotoxic drugs or drugs with nephrotoxicity are ACE inhibitors, ARBs. Of course, in early stages, they are very, very important. However, one has to keep in mind that most of the drugs can have some nephrotoxicity. Even if we have a list of drugs, that list is not going to be complete. In an ICU setup, if we are giving certain antibiotics, then their dose, even if it is not nephrotoxic, many times the dose has to be adjusted. So, as a blanket rule, of course, in general practice, NSAIDs and aminoglycosides are nephrotoxic, but there are various other drugs, like oncologists are aware of many of the chemotherapeutic agents are nephrotoxic. In ICU setup, many of the Uh, Antibiotics can have nephrotoxicity. If there is a neurosurgical unit, mannitol can have its nephrotoxicity. A contrast procedure causing IV contrast is also having nephrotoxicity. So these are various agents which can have nephrotoxic effects.
Sir, role of peritoneal dialysis, and it is frequently done in USA. Why not here?
Look, peritoneal dialysis, as I told you, when the patient lands his end
Yeah.
stage kidney disease, either we go for the patient, we give patient the advantage of dialysis. Dialysis can be hemodialysis and peritoneal dialysis. Peritoneal dialysis is usually a procedure where patients are trained how to do the, after putting a catheter or a PD catheter in their abdomen, the patients are trained how to do the procedure at home. Now, peritoneal dialysis is a very excellent procedure. It also preserves the patient's uh, residual renal function. Now, the point is that if we add up the total cost of dialysis, it is usually more expensive. Many times, patients, even after being explained several times about the procedure of peritoneal dialysis, they are not ready because either they have to do it or some of the family members have to do it. Third thing, the cost is often not covered by the insurance agents in most of the patients in our setup. Most of the patients are self-sponsoring. In United States, most of the dialysis is being taken care of by, in United States and many of the advanced countries in Europe, and in places like Japan and all, the dialysis is taken care of by the insurance agents or by the governments. So the people have a choice. They can go for peritoneal dialysis, and also the dialysis units are situated far off in many of these places, so the patients normally opt for peritoneal dialysis, and they have the freedom to opt for peritoneal dialysis. But well, I must say that peritoneal dialysis is as good as hemodialysis, and those patients who need to opt for it can go and opt for it.
So Dr. Deepak Jaiswal is asking, can you go with opiates for pain if needed?
Look, opioids can be given. Opioids are actually it obviously we do not go give opioids in general practice. Opioids are restricted. Their use has to be decided by an anesthesiologist or in post-operative situation. Of course, we can give things like tramadol and all, but per se, opioids are not to be given on OPD basis. And even if they are given, they are renally safe. Definitely they are renal safe. They don't have any direct renal side effects, but their use has to be specified, and they used to be done by someone who is specialized with the use of opioids on a daily basis, especially in post-operative situations and in the hospital.
And sir, role of
Yeah.
N-acetylcholine in contrast-induced nephrotherapy.
uh, yes, so far it has been seen that contrast-induced nephropathy doesn't have a fixed treatment. Contrast-induced nephropathy can happen with especially high osmolar contrasts. But what has been important is that to prevent contrast-induced nephropathy, patients have to be adequately hydrated. And if the patient has got, I mean, more important than NSL-cysteine is, NSL-cysteine role is again not very certain. It has got a debatable role because we do not have anything else, and as it doesn't do any harm, we go for NSL-cysteine. But more importantly, patient has to be adequately hydrated and stop if the patient is having any nephrotoxic drug. And if the patient has to be properly counseled, that there can be a transient rise in serum creatinine after the contrast procedure. Along with that, of course, NSAIDs are given.
Sir,
Yes, the
Dr.
next question.
Sanjay Kumar Rathi is asking, I have seen proteinuria running in families ending up in ESRD. Can they be put on ARBs early, keeping on check urine microalbumin to enjoy normal life expectancy?
Yeah, that's a very good question. Actually, proteinuria in those patients who have got proteinuria, obviously we have to assess what is the cause of proteinuria. If there is proteinuria without diabetes, then the patient most likely has got some other kind of glomerular disease. For that, we have to go for a kidney biopsy to exactly ascertain why the patient has got proteinuria. ARBs or ACE inhibitors are non-specific management of proteinuria. Along with that, if the patient has got certain glomerular disease, then we can go for adding a certain treatment, either with steroids or other secondary agents for treatment of glomerular disease. And usually these treatments are prolonged, these treatments are lifelong treatments. But if we treat proteinuria or the cause of proteinuria early enough, then it delays the progression to chronic kidney disease. If a patient has got diabetes and proteinuria, then most likely it is due to diabetic kidney disease. In these patients, of course, ACE inhibitors or ARBs are also very, very important in delaying the progression of diabetic nephropathy. So, both ACE inhibitors and ARBs can be given in most of these patients to check proteinuria for a long time.
That's all from
Okay, I
Dr.
think we are
Inep,
done
sir.
with questions.
Dr.
Hello.
Nitesh? Yes, sir.
Yeah,
Yes, yes.
yeah. There is a question. As a general practitioner, we deal with the diarrhea patients many a times. So, what
Mhm.
would be an alarming symptom or alarming sign where we should think about the patient is landing into ARS?
Look, if a patient has got diarrhea, and most of the patients of diarrhea do not come to the hospital. So first of all, if a patient with diarrhea comes to a hospital, that is the first alarming sign that the patient is definitely having intractable diarrhea, sometimes along with vomiting, and also the depletion is so significant the patient lands up into the hospital. These times there is so much of volume depletion that the patient would land up in the hospital in hypotension and severely volume depletion condition. Hypotension is a very important marker that these patients, if they have gone into hypotension, there is volume depletion so significant, then this can lead to acute kidney injury. And of course, the urine output is another indicator. If the patient complains of several episodes of diarrhea followed by decreased urine output, then of course that's an alarming sign for us to realize that the kidneys are getting involved and patient has not been adequately hydrated.
Sir, as in case of obstructive nephropathy after urosurgical procedure, if SCR still deranged, does it need any empirical management or should you wait and watch as it is persistent CKD?
Look, if a patient has got some kind of obstructive uropathy, I mean, suppose the patient has got some urological obstruction or pelviureteric obstruction, and the patient suddenly has come up, usually you would expect the patient to have a normal kidney function much earlier. But if you do not have a proper history and the patient comes with some obstructive uropathy, and your urologist has put on a stent, or a urologist has gone for some procedure like PCN to relieve the obstruction, usually if the whole thing has happened overnight or in a few days, or in other words, if the patient has got an AKI, then most likely his creatinine is going to come down. But if your creatinine doesn't come down in course of time, then we have to assess if the problem was long enough, if there was cortical thinning already, or in other words, the patient had already gone into CKD. If the patient had already gone into CKD because of chronic obstruction, then even after urological intervention, the patient may not have much recovery or much improvement even after urological improvement. Even after urological procedure, there may not be significant improvement.
Right. So, one more
So,
question. As we deal with the patients from diabetes mellitus and hypertension, as a general practitioner, uh, what could be the your special recommend for general practitioner to monitor diabetic and hypertensive patients?
okay, as I told at the beginning of chronic kidney disease in our discussion, that diabetes and hypertension are the most common causes of chronic kidney disease. In diabetics, it's very important to assess that a good glycemic control actually delays the progression of CKD. If the patient with diabetes got poor glycemic control, then it actually enhances the progression of chronic kidney disease. So in diabetics, along with that, in hypertensives, the poor blood pressure control can progress and delay can accelerate the progression of CKD. So in both diabetics and hypertensives, it is important to delay the progression of CKD by controlling blood sugar levels and by controlling blood pressure levels. we have to also look into other cardiovascular risk factors in these patients, and also we have to look into avoiding other nephrotoxic drugs in these patients. And also, if these patients have any anatomical urological abnormalities like prostatic enlargement as often present in elderly patients, then those things have to be taken into account. So therefore, in diabetics and hypertensives, all we can do is manage their diabetes properly, manage their hypertension properly, manage their diet properly, manage their salt restriction properly, manage their lifestyle properly, and including weight reduction measures, because obesity also is a compounding factor. All these factors would positively contribute towards delaying the progression of chronic kidney disease in these patients.
Can excess marketed protein formula intake by gym goers lead to AKI?
Yeah, of course, we have. This is something we come across a lot of times. A lot of gym goers actually take up protein supplements. They are not very sure about the contents of the protein supplement. Many times this protein supplement have got other elements which can be potentially harmful, and they do not even have a regulation of how much protein they are taking. So I think this is something which has to be taken with a lot of caution, because many times they do not have any significant problems, but a lot of them are unable to report to a hospital. Many of them have come to us with actually proteinuria, have actually causes of unknown chronic kidney disease. Like we are not able to exactly ascertain what could be the cause of chronic kidney disease in these patients. But if we elicit a history, we see these patients have been taking some kind of supplement or the other. Other than protein itself, many of these times these supplements have got potentially harmful substances in the name of herbal elements. And also, I would strictly request all of you to desist to whoever comes to you with such a request or such a query about similar requests. Then they should be desisted from taking such supplements. Beyond that, of course, um, I do not have a detailed list of the elements available in various products, but many of the products are, not all of them, but many of the products are potentially harmful.
So there is one more question. Your expert opinion on keto diet and herbal supplements.
As I just told you, what is basically a keto diet? A keto diet is basically a restriction of carbohydrate and increase in your protein and fat supplements in the diet. But as I told you, a typical Indian diet with uh, 60 to 70% of carbohydrates, 15 to 20% of fats, and 10 to 15% of proteins is good enough. We do not have to entirely replace our carbohydrate element, because as we understand the basic elements of a human body, our majority of what are the functions of our various ingredients of our food. A food has got six elements as carbohydrates, fat, protein, vitamins, water, and minerals, that we all understand. So carbohydrates are the potential source of energy. Majority of our energy or calories should come from carbohydrates. Proteins are muscle building elements, and fats are, of course, have got also responsible for giving lesser amount of energy. But the most important element that should contribute to our energy element is carbohydrates. Now if we replace these carbohydrates with other supplements, then those kind of biochemical process that happens inside the body would be, I mean, instead of normal glycolysis, we will be having gluconeogenesis, which is potentially harmful. Those should not be. If someone is trying something, it can be for a very short period of time, but on a prolonged period, it can be potentially harmful. Second thing, I would say strict no to herbal elements. Many of the herbal elements have landed up patients into ICUs with potentially catastrophic consequences. No one knows, even the people who, I mean, anyone can make a herbal element and produce it in the market, and they will produce it some cheap advertisement on television, and most of the people will be fooled by these things. I think those herbal elements are potentially harmful, and most of the sensible people should try and avoid these herbal supplements.
Yeah, thank you, sir. Thank you once again on behalf of RPG Life Sciences. We extend our gratitude towards you, sir, for taking this session, and it's really blessings for the practitioners. So we'll catch up you once again, sir. Thank you, sir.
Definitely. Thank you so much. Take care of all of yours. Once again, thank you very much.
Yeah, bye bye.
Bye bye.